Hello, everybody. It's time for another Puscast covering the last 2 weeks of February. Although we're several days short, this is going to be a much shorter than usual Puscast, as I couldn't really find a lot of stuff at the end of February 2011 to thrill and amaze you. This is, as always, brought to you by Pusware LLC, publisher of the Infectious Disease Compendium, your Uber hyperlinked electronic guide to infectious diseases. My growing multimedia empire with links to my books and my iPhone apps, etc., is all at moremark.squarespace.com. Because the world needs more Mark Crislip. Don't forget, you are more than welcome to write me glowing reviews on iTunes. And The Pus Whisperer, A Year in the Life of an Infectious Disease Doctor, is available on sale on Amazon for the Kindle and all Kindle reading apps for a mere 99 cents. I think I get 34 cents out of the deal. So go buy it. I'm worth 34 cents. Am I not? Now let's move on to the literature. Pregnant women, but not pregnant men for some reason, are somewhat understandably loath to get the flu vaccine. Nobody wants to hurt their baby. This study, published in the Canadian Medical Association Journal, compared women who received the flu vaccine versus those who had the pneumococcal vaccine, and found that women who had the flu vaccine had bigger babies. They had fewer kids who were small for gestational age, and their mean birth rate was 3% higher. Also, the women who got the flu vaccine were much less likely to have a viral upper respiratory tract infection during this time, 49% lower, with a p-value that gets down to the fourth digit, which is pretty good. This is evidently one of 4 publications in the last year that show that women who get the flu vaccine during pregnancy were less likely to have kids who are small for gestational age. So being protected during the flu season appears to be important. So not only does it not cause birth defects nor autism, you'll probably have a bigger, healthier baby if you get the flu vaccine. And of course, it's the women who die when they're pregnant and get the flu, and that's bad for the fetus as well. It appears to be a win-win-win-win-win situation. The theory behind the meta-analysis, as I've said before, is if you take a bunch of lousy studies and put them all together, you get a good study. I.e., if you take all the cow pies and put them in a pile, you get gold. I'm not so certain that's the case. But they are nice for overviews on a topic, and meta-analyses of meta-analyses suggest that they don't predict reality with great efficacy. I.e., future well-done studies have about a 50-50 chance of proving the meta-analysis wrong. But this study was published in the Annals and looked at the efficacy of oseltamivir or zanamivir in the treatment of flu. Not unsurprisingly, the sooner you got it, the better your outcomes. And there seems to be a slight edge with zanamivir for decreasing signs or symptoms, although overall benefits were shown more for oseltamivir. What, you ask, were those benefits? Well, decrease in death. Not bad. The absolute decrease in mortality in high-risk patients was 17%. Not bad. It decreases hospitalizations from around 12 per thousand down to somewhere around 3 to 9 per thousand. It, of course, decreases symptoms, and depending on the studies, may show decreased risks for pneumonia, otitis, stroke, TIAs, and other vascular outcomes. So, the use of antivirals like oseltamivir is not like using penicillin for viridin strep endocarditis, which is an overall thermonuclear weapon, but does give incremental improvement in patients, especially high-risk patients. It's neither worthless, as some of the alternative medicine wackaloons will suggest, nor is it the be-all, end-all for influenza treatment. But it is a useful antiviral agent. Flu season is finally kicking up for the year 2012, kind of late in the season. If you want to know if flu is coming your way, check Google flu trends. This is really cool, but Google searches for search terms around influenza, and it predicts flu in the community by about a week or two. This has been demonstrated in clinical infectious diseases, again, to show that it has a good correlation with crowding and influenza rates. According to Google Flu Trends right now, it's moderate in the United States and kicking up in my state of Oregon. So flu season is here and will hopefully end soon, since summer is just around the corner everywhere but Oregon probably. But flu trends will beat out the CDC by about 2 weeks if you want to know what's going on in your community. I just checked Google Trends to see what the top 10 trends for searching in the United States are right now. And it's the top 2 things are something perhaps scarier than influenza. As of the 3rd of May, the number 2 is tornadoes, and even scarier, Rush Limbaugh. I can think of nothing scarier than a pandemic of the Limbaugh virus. As you guys know, there are things that I tend to obsess about, and topics I kind of ignore. I really don't care about hepatitis C, I'm afraid to say. I don't treat it. I'm always fascinated, though, by the interactions of infectious diseases and the environment. And this study looked at climate and dengue outbreaks in New Caledonia and found that dengue is associated with peak humidity and peak rainfall, but not peak temperature, and usually preceded the hottest days of the year. So when you get wet, humid weather, it was dengue weather. As I mentioned before, dengue is creeping north into the United States. It's now in the Florida Keys and coming our way with climate change. So you can predict when you're going to see your dengue outbreaks, and somewhat by when it's hot and humid, just like Legionella occurs more likely after thunder showers. Mark Twain said everybody complains about the weather, but nobody does anything about it. I'm not complaining, however. I just think it's fascinating, the interactions between the environment and all its different manifestations and human infections. So much more interesting than other parts of medicine. I think there must be an inverse relationship in medicine between how interesting a topic is and how well it's reimbursed. I am old enough to remember when patients with HIV disease died in droves. It doesn't happen much anymore, and the antiviral therapy has been an amazing change in the practice of medicine, but not without their complications. This study looked at the risk of protease inhibitors and sudden death or stroke and found no association between a given PI and those side effects. However, they did find there was an increased risk with cumulative exposure to these agents. HIV has changed in some part from a disease where you're going after the virus to a disease where you're trying to manage the complications of the treatment and the chronic inflammatory state associated with HIV. But it's nice to know that there's not an individual PI that is associated with stroke or sudden death. Like all infections, HIV is not a virus, but a family of closely related viruses. And you can be infected with several strains of an HIV virus, either initially or get a secondary infection with HIV when you already have HIV, a super infection. Both of which situations are bad. Patients who are infected with 2 HIV viruses, either as an initial infection or as a secondary infection later, progress faster and need antiretrovirals sooner than those that have a single strain of HIV. I think that's important, that if a patient thinks, oh, I have HIV, I don't need to worry about protecting myself as long as I have risk behaviors with other HIV patients, that may not be so wise. That if you get 2 of the wrong strains together, you'll progress faster and do worse. I find it increasingly curious that the reason that we get sick may not be the bug, but may be ourselves. two studies that have looked at variants in toll-like receptors and the risk of infection. In one study, African American women were more likely to get PID if they had variants in the toll-like receptor genes 1 and 4. For liver transplant patients, they were more likely to get invasive CMV disease after liver transplant if they had a variant of toll-like receptor 2. These are not clinically useful bits of information, but there is this growing torrent of data to suggest that the reason people get sick is less the bug and more the genes of the person having the bug. Hopefully someday we'll be able to smear out your genetic code on a slide and say, oh yeah, you got sick because you have this polymorphism in your toll-like receptor. It is becoming increasingly relevant to ask for whom the gene tolls. It tolls for thee. That's a bit of a stretch. What the hell? Should I have made a Toll House cookie reference? Toll Bridge? I don't know. I'm sure as the time goes, there'll be a standard pun used in the article headlines for these problems. There was an outbreak of E. coli that was associated with ready-to-bake cookie dough. They say in the article that ready-to-bake cookie dough is not ready-to-eat food. The hell it's not. The best thing to do is to eat raw chocolate chip cookie dough. I don't know what they're talking about in this article. Although, of course, raw cookie dough is a good source for infectious diseases from eggs and the like. But what's the point of buying your Nestle's Toll House cookie tubes if you're not going to chow down on the dough raw? I'll take my risk for infection, I suppose. They just call it brand A cookie dough. I don't know which one brand A is. But I would hope in the future that brand A would consider making their cookie dough ready to eat, because most people, including kids, consider cookie dough ready to eat. I wonder if the patients that ate the cookie dough were Helicobacter negative. Interestingly, Helicobacter is protective against Shigella and other infectious diseases. They found in Israel that if you had Helicobacter, you are less likely to get diarrhea for any reason and more likely, especially, not to get Shigella. They hypothesize that perhaps this is due to increased local inflammatory response in the stomach that's protective, or perhaps it is a consequence of increased gastric acid secretion. There's been other studies to show a protection of Helicobacter for diarrheal illnesses. It's interesting, they suggest that Helicobacter is also associated with decreased esophageal diseases, decreased asthma, and decreased allergic diseases. Sort of the hygiene hypothesis again. The more infections that we have, the better off our immune system is for preventing allergic diseases. They predict that perhaps as we get rid of Helicobacter, which is associated with gastric cancer and lymphoma, we might see an increase in diseases such as Shigella, esophageal diseases, and asthma as a consequence. Maybe rather than putting E. coli in the cookie dough, they should put Helicobacter in the cookie dough. Probably a bad idea. But it is the ongoing issue that no good deed ever goes unpunished in medicine. Infectious diseases is nothing but evolution in action. And this study looked at the issue of what happens to patients on a TMP sulfa prophylaxis. Well, not unsurprisingly, patients on the TMP prophylaxis were more likely to have pneumococcus that was resistant to TMP, or as they say, non-susceptible. The problem is that the genes that code for TMP sulfa resistance often occur in islands of multi-drug resistance, and unfortunately, if you have TMP non-susceptibility, you're also more likely to have penicillin, erythromycin, rifampin, and multi-drug resistance. So your patients who are coming in with a lobar pneumonia on TMP sulfa for their pneumocystis prophylaxis or other prophylaxis, is that a word? Prophylaxis? Prophylaxisosity? Anyway, suspect that if they have pneumococcus that they have a multi-drug resistant pneumococcus until the cultures get back, and you should probably have them on vancomycin. But I've talked before how even short courses of antibiotics can lead to resistant organisms for months after the exposure. It's an important part of the history in determining what empiric antibiotics to give patients. Of course, everyone's going to get Pip/Tazo and Vanco no matter what, right? I mean, that's all anybody knows how to give anymore. Other risk factors for having an MDR bacteria besides being on TMP sulfa was looked at in a CID article, or actually, CID. And they found that being in the hospital within the last 90 days, or residency in a nursing home, the latter being but 90 days out from hospitalization increases your risk of being admitted with a pneumonia with an MDR organism, MDR standing for multi-drug resistance. A little bit of upfront exposure can lead to a lot of long-term resistance. Over at Science-Based Medicine, I spend my time with the wackaloon world of alternative medicine. And this headline struck me as belonging in that category. Blood purification may decrease mortality in patients with sepsis. This was a poster out of the Society for Critical Care Medicine meeting in Houston, Texas. And they found that patients who had blood purification, which is a lousy term, but this was hemofiltration, hemoperfusion, plasma exchange, or dialysis, had decreased mortality in pooled data looking at the results of 827 patients. The p-value was 0.00001. Whether it's because you're removing the evil humors, i.e. the endotoxin, or removing the other evil humors, i.e. cytokines, or both, is uncertain. It is an interesting intervention and does have some biologic plausibility, but I'm not certain at this stage what would be the best, quote, blood purification, unquote, you should do. And is often the case with meta-analyses, they may not be validated by future well-designed clinical trials. But we need, evidently, a well-designed, randomized clinical trial. You, get to work on that, would you? I know how impure my blood is at baseline, so perhaps I should have this done prophylactically. I have been convinced for years that treating fevers is bad, at least with Tylenol and NSAIDs. Every study that has looked at treating fever with pharmacologic agents has shown poorer outcomes, increased mortality, and prolonged illness. Fevers are, generally speaking, good. This study out of France used external cooling in patients who were septic. They randomized patients to receive nothing or external cooling, and there was about 100 in each group. They found that those who had external cooling had less vasopressor response and a more rapid turnaround in their sepsis, and a 14-day mortality rate that was decreased. However, the ICU mortality rate remained the same, and the hospitalization mortality rate remained the same. I kind of look at the study is if you do enough analyses of data points, you'll find significant correlations that have no clinical relevance whatsoever. Often the case in clinical trials. When you look at the differences, it was only like 10%, so it was not that clinically significant. It looks to me more like the random noise you get in clinical trials than actual significant, i.e. clinically significant outcomes. Still, it is interesting that patients had less vasopressor requirements. I still think fever is good for you, and in the overall balance, messing with the fever response should be avoided unless you have other strong pathophysiologic reasons to decrease the temperature, poor cardiac output, etc. Another bee in my bonnet, or bug up my something. This study looked at bacteremia and death. Now, everybody knows when you come into the hospital, you're likely to die early if you have a bloodstream infection. But this study looked at the late mortality after bloodstream infections and found that patients who had a community-acquired bacteremia had a increased long-term mortality over the next year. What did they die from? Well, infection-related, whatever that is. Malignancy, nothing to be done there. But interestingly, 24% died of cardiovascular diseases. I keep harping on the fact that infections are inflammatory and inflammation is prothrombotic, and people that get infections have more vascular events. Someday we're all going to be discharged on antiplatelet agents. It's always nice to salvage a central venous catheter if you can. This was a series of patients where they salvaged 11 of 13 by using a daptomycin lock on the infected catheter. For them, what are not in the loop as to what a lock is, you fill the catheter up with a substance, it kills off the bacteria and sterilizes it. None of the infections were with Staph aureus. They had Staph epi, hominis, hemolyticus, and 2 Enterococcus fecalis infections, and all but 2 of them had their lines salvaged with the daptomycin lock. So no one has the courage, including me, to try and do it with Staph aureus, at least not using an antibiotic lock. I will say, against my better judgment, I have salvaged lines infected with both Staph aureus and gram-negative rods using an alcohol lock. Alcohol has the advantage of killing everything, including my liver, though hopefully not soon, and may be beneficial. This was a meta-analysis of alcohol locks used as a preventative, not therapeutic intervention for pediatric patients with central lines, and found that indeed the alcohol lock was effective. And the alcohol lock decreased infections in these patients by 7.67 per 1,000 catheter days. They figure you had to use alcohol for 108 days to prevent 1 line infection. And to prevent 1 catheter replacement, you had to use it anywhere between 120 and 600 days. It was without major complications. For what it's worth, when I have patients who have recurrent line infections, I have used catheter locks on them, and as best I can tell, with all the problems inherent with confirmation bias, it is an extremely efficacious way to prevent infections in catheters. Which always makes me wonder why alcoholics have so many infections, because you'd think their blood would be sterile. Doesn't seem to be the case, unfortunately. Shortly after lumbar punctures or other procedures that involve invading the spinal fluid, patients can come down with acute bacterial meningitis. I've seen a hodgepodge of these over the years, or a smattering perhaps. And it's usually an oral strep salivarius. The strep comes from several places. One could be the operator's mouth as they pant upon the spinal tap. It's why you should wear a mask when you use the spinal tap. Although it could be from the patient if they were chewing gum, for example, during the procedure and became bacteremic and then had trauma into their spinal fluid. This tends to be a particularly nasty illness with a fairly rapid onset because the infection tends to completely bypass the bloodstream, and so you get a high inoculum. You get a high initial inoculum right into the spinal fluid. I mention this because there's a review of strep salivarius meningitis which emphasizes that it's a nosocomial infection. And if you do procedures that require you sticking needles into people's backs, might I suggest that you wear a mask, especially if you're doing it to me or mine. More gene problems. One is that polymorphisms in the PKP3-SIGIRR-TMEM16J gene region are associated with an increased susceptibility to tuberculosis. Well, I think that's obvious. The other is that there are cytokine gene polymorphisms which determine outcome in Candida albicans infections and invasive candidemia. If you have polymorphisms in your IL-10 or your IL-12B genes, you are more likely to have disseminated candidiasis. So again, the answer may be not the bug, but the host that is the risk for developing a variety of infectious diseases. My goal, if I ever get a parrot, is to have it say polymonomorphism. I'd probably be the only person who would find that funny. The PET scan looks increasingly beneficial in an FUO workup. The downside, of course, is that you can't get anybody to pay for a PET scan because they are horrifically expensive. This study compared the PET scan versus the tagged white cell scan in the evaluation of 23 patients with FUO. They found the PET scan gave a sensitivity and a diagnosis of 86% of the time versus 20% of the time for a tagged white cell scan. I've come to the conclusion at least a decade ago that tagged white cell scans are a waste of time and have quit doing them in FUO workups, with very rare exceptions. But I've been using the PET scan when I can browbeat the insurance company into allowing me to get one, although I can't give a good summary of my experience, and of course, the 3 most dangerous words in medicine are, in my experience. Be that as it may, it's a useful adjunct in the FUO workup, though so far I have seen more patients who have had a PET scan for cancer and have turned out that it had an infectious disease than I've had positive PET scans in FUO patients. And finally, just a study of interest, they took some dirt from the areas around agricultural systems that have animals, and they looked at them for antibiotic resistance genes, and they could find tetracycline, erythromycin, and streptomycin resistance genes in the dirt around animals on farms. So yet another reservoir for resistant infections. And so ends another exciting Puscast, a review of the infectious disease literature for the last 2 weeks of February 2012. As always, go on to iTunes and write my glowing review to feed my ravenous yet fragile ego. And if you're interested, you can always go to my website and give me money. Otherwise, as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation. Goodbye.